Let's dive straight into the Step 2 CK Next Best Step diagnostic arc for anemia, hemolysis, sickle cell disease, and transfusion reactions. When you're triaging anemia, your very first moves are checking the mean corpuscular volume, or MCV, and the reticulocyte index. It's a simple branch point. Low reticulocytes, that means bone marrow underproduction. High reticulocytes, you're looking at peripheral blood loss or hemolysis. Combine that initial branch with the RDW, the peripheral smear, and a thorough clinical history, checking for kidney disease, chronic inflammation, or bleeding. If you're looking at a microcytic or normocytic anemia, definitely consider anemia of chronic disease. It's driven by inflammatory cytokines, specifically hepcidin. Think of hepcidin as a lock. It traps iron in macrophages and lowers gut absorption. Because of this, you'll see low serum iron and low total iron binding capacity, but a normal or even elevated ferritin level, because those iron stores are just trapped. Now, you'll often need to contrast iron deficiency with thalassemia minor. A really quick way to do this is the Mensur index, which is just the ratio of MCV to RBC count. A ratio below 13 points toward thalassemia minor, where you have a low MCV but a normal or even high RBC count. A ratio above 13, that favors iron deficiency. And here is a crucial Step 2 point. For adult patients with confirmed iron deficiency, you absolutely must search for occult blood loss, especially GI bleeding or colon cancer. To confirm iron deficiency, look for low ferritin, high TIBC, a high RDW, and quite often a reactive thrombocytosis. Beta thalassemia minor, on the other hand, presents with normal to high iron, target cells on the smear, an elevated hemoglobin A2 on electrophoresis, and a characteristically poor response if you try empiric iron supplementation. Shifting gears to macrocytosis, systematically rule out things like hemolysis, liver disease, hypothyroidism, and maturation defects. If you're suspecting a bone marrow disorder, like sideroblastic anemia, look for a history of alcohol use, lead toxicity, or isonias. Check for basophilic stippling on the smear and ring sideroblasts in the marrow. You treat the underlying cause, though pyridoxine helps in selected cases. For maturation defects, think about folate deficiency, which is commonly linked to alcohol use, malnutrition, or pregnancy. Vitamin B12 deficiency causes a megaloblastic anemia, so you'll see macroovulocytes and hypersegmented neutrophils. Whether it's from pernicious anemia, a previous gastrectomy, or a strict vegan diet, keep an eye out for physical signs like a shiny tongue or pale palmar creases. The big differentiator from folate deficiency is that B12 deficiency presents with neurologic findings. We're talking paresthesias, ataxia, cognitive changes, and posterior column dysfunction. You confirm B12 deficiency by checking for indirect hyperbilirubinemia and elevated LDH, which happen because of intramedullary hemolysis. Now, pay attention to this classic high-yield clinical trap. Never, ever treat a suspected B12 deficiency with folate alone. While the folate might actually correct the macrocytic anemia, the irreversible neurologic injury from the B12 deficiency will just silently progress. Okay, what if elevated reticulocytes point you toward hemolysis? Your core lab findings here are going to be a high LDH, low haptoglobin, and high indirect bilirubin. If it's intravascular hemolysis specifically, that will present with hemoglobinuria. Always make sure to check a direct antiglobulin test, the Coombs test, so you can rapidly distinguish warm or cold autoimmune hemolytic anemias from non-immune causes. Let's look at specific hemolytic triggers. G6PD deficiency causes hemolysis right after oxidative stress. Think medications like dapsone, nitrofurantoin, or primaquine. Then you have paroxysmal nocturnal hemoglobinuria, or PNH, which causes hemolysis, cytopenias, and unusual venous thromboses due to the absence of the CD55 and CD59 proteins. You diagnose PNH using flow cytometry and treat selected patients with complement inhibition. The smear findings will guide your diagnosis here. Spherocytes in a Coombs-negative patient with splenomegaly, that's hereditary spherocytosis. Schistocytes indicate microangiopathic hemolysis, which means you need an immediate evaluation for TTP, HUS, or DIC. Macroangiopathic hemolysis also causes schistocytes, and you'll commonly see this when a deteriorating mechanical aortic valve physically shears red blood cells as they pass by. Moving on to sickle cell disease, the definitive diagnostic test is hemoglobin electrophoresis. Someone with sickle cell trait will have both hemoglobin A and S. But full sickle cell anemia is defined by the complete absence of hemoglobin A and a predominance of hemoglobin S. It's this HbS polymerization that drives the whole clinical picture: vaso-occlusion, chronic hemolysis, functional asplenia, and a massive infection risk. Baseline maintenance for sickle cell patients is all about infection prevention and hematologic support. This means making sure they get the pneumococcal vaccination, giving prophylactic penicillin in early childhood, continuous folic acid supplementation, and starting hydroxyurea to reduce the frequency of those recurrent vaso-occlusive crises. When an acute vaso-occlusive crisis does happen, it requires immediate hydration, NSAIDs, and IV opiates for analgesia. In young children, this frequently shows up as dactylitis. Crucially, you must investigate and treat the underlying trigger. Any fever in a sickle cell patient requires urgent broad-spectrum antibiotics to cover encapsulated organisms. Acute splenic sequestration presents in young children with hypovolemic shock, left upper quadrant pain, a rapidly enlarging spleen, and an acute drop in hemoglobin with concurrent thrombocytopenia. Basically, massive vasoocclusion traps a huge portion of their blood volume right inside the spleen. The immediate next best step is isotonic fluid resuscitation and a red blood cell transfusion. You have to contrast splenic sequestration with an aplastic crisis. Both of them cause a sudden, severe drop in hemoglobin, but splenic sequestration features an elevated reticulocyte count. An aplastic crisis, which is usually triggered by parvovirus B19, actually arrests erythropoiesis entirely, resulting in a distinctively low reticulocyte count. Next is acute chest syndrome, which is typically triggered by a fat embolus or pulmonary infection. Diagnosis requires seeing a new pulmonary infiltrate on a chest X-ray alongside fever, hypoxemia, chest pain, or respiratory distress. Initial management is straightforward. Broad-spectrum antibiotics, specifically ceftriaxone and azithromycin, plus IV fluids and pain control. The pathophysiology of acute chest syndrome involves a really dangerous, vicious cycle. An initial infection or embolus leads to regional alveolar hypoxia. That hypoxia directly triggers increased red blood cell sickling right there within the pulmonary vasculature, which causes further occlusion, extensive pulmonary infarction, and then even worse hypoxia. For severe neurologic complications like an ischemic or hemorrhagic stroke, or in cases of severe acute chest syndrome, the absolutely indicated management is an exchange transfusion. This actively removes the sickled cells and lowers the overall blood viscosity. You only utilize a simple transfusion if an exchange transfusion is completely unavailable. When you are managing severe anemia and giving transfusions, base it on symptoms, hemodynamic instability, or specific hemoglobin thresholds. Always monitor closely for adverse reactions and stop the transfusion immediately if you suspect one. An acute hemolytic reaction causes fever, flank pain, hemoglobinuria, and a positive Coombs test. TRA-all-lite presents with hypoxemia and non-cardiogenic pulmonary edema within 6 hours, whereas TACO causes volume overload and hypertension.
Finally, keep in mind that delayed hemolytic reactions can occur days to weeks after a transfusion due to an anamnestic antibody responses. A critical point regarding transfusion volumes, particularly during splenic sequestration, transfuse cautiously. Overtransfusing can trigger a very dangerous hyperviscosity syndrome when the spleen eventually decongests and returns all those trapped red blood cells back into the systemic circulation.